Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, my guest is Dr. Loria Nahatis. Dr. Nahatis is a board-certified pediatric dentist practicing in Dallas, Texas. She graduated summa cum laude from the University of Texas at Arlington, obtained her DDS from Baylor College of Dentistry, and completed her pediatric residency at the University of Maryland, Baltimore College of Dental Surgery. She's one of only a select group of pediatric dentists in the country who were chosen to complete specialized training with world-renowned ENT sleep surgeon Dr. Soroush Zaghi, where she gained a greater understanding of functional lingual frenuloplasties. And we'll be talking much more about that during today's show. We will also be discussing topics such as how Dr. Nahatis became so passionate about pediatric airway health after practicing for many years with a more traditional approach to pediatric dentistry, what obstacles she has faced in her quest to detect and address airway compromise in younger patients, how helping patients in this manner has impacted her practice and the community at large, what diagnostic and treatment approaches she has found to be most successful, including as it relates to tongue-tie releases, what she sees for the future of the profession of dentistry regarding taking a more proactive approach to treatment, how she balances the challenges of being a mom, wife, business owner, pediatric dentist, and national lecturer, and much, much more. So without further ado, let's get on to today's episode with Dr. Loria Nahatis. Enjoy the show, everybody. Welcome to the Doc Podcast, Loria.
Oh, thank you for having me, Dr. Mike. How are you today?
I'm good, thank you. Had a great day. Actually recording a couple podcasts today, which is just kind of fun. I've gotten to that point where the schedule's busy enough that I actually record multiples in a day. And first time when I started doing it, I thought there's no way I could do that. And now I actually enjoy it. It's fun.
That's awesome.
So thank you for coming on and taking the time. I know your schedule is super busy. You have a lot going on, both as a practitioner and as a parent. And so actually we can even talk about that a little bit later on too, how you balance those things. But before we get into the details of talking about the content we're going to talk about today, what is it that you would want the audience to know about your journey? How did you get to be the Dr. Nahatis that you are today?
Well, it actually started really early. My uncle in Greece is a dentist. So when I used to go, and I'm half Greek, so I used to go visit Greece quite often when I was younger. And I knew I wanted to be a dentist at a very young age. I was like 12 or 13. And then I worked in a general office when I was a senior in high school, and I did not like it. And the dentist there saw that I was kind of grossed out when the patient spit out their dentures. And he was like, there are other specialties in dentistry. It's not just this. Do you like kids? And I was a kid at that time. I was like, yeah, I like kids. And so he said, my good friend is a pediatric dentist, and I can have you shadow him for a little bit if you'd like. So I went and shadowed him, and that was where I knew this was going to be what I'm doing the rest of my life. So I knew since 18, and I'm going to be 48 this year. So I've known a long time that I wanted to be, I've been in this field for a very long time. I started off shadowing. He hired me for the summer because, as dentists, we know summertime, especially with kids, is like a super busy time. And went to dental school and knew this is what I wanted to do. And I was super happy, drilling, filling, like giving injections to patients where they didn't even know that they were getting an injection. It was a real challenge, and I just loved like getting them through that. But then once I learned about this, because of my daughter, and I feel like a lot of people, a lot of people that are in this space and have learned more, there's a personal side to it. Yeah. And one of my dear friends who was a co-resident of mine actually started going down this journey like a few years before I started, and she noticed a picture of my daughter on Instagram, and she said, Loria, your Alice, she's so adorable, but I would love to share some things that I see, and we could be very open and frank with each other, just because as a co-resident, like we lived together essentially for a couple years in the residency. So she noticed that she had dark circles under her eyes, she had a very deep bite, narrow arch, and at that time I knew we would start start early, and she was she had just turned 4 years old. And I knew we'd start early, but in my mind, early was age 7. Mm-hmm. Yeah. And I was like, well, yeah, Lauren, I know we're going to start ortho, we'll wait till she's 7. And she's like, no, how is she sleeping? Does she sleep with her mouth open?
About how long ago was this?
This was in 2000. So Alice was 2014. So 2018.
Oh, wow. So a little while back.
Yeah. So she, like I said, she just turned 4 years old. So she asked me if she slept with her mouth open. Mm-hmm. And I was very offended, actually, because I was like, no, she does not sleep with her mouth open. Because, you think open mouth posture like Napoleon Dynamite, like no. Yep. And so she said, okay, fine, go take a picture of her an hour or two after she falls asleep tonight and send it to me and text it to me. So I went in her room.
This colleague was practicing pediatric dentistry, but was doing airway related treatment. Is that?
Yes. Okay. She started because her dad and uncle owned a practice in she's in Massachusetts. Okay. And they kind of did ortho and pedo. Like they would do a lot of bracketing, and just because where they lived, like they needed somebody to do have some orthodontics. And we had in our pediatric training some orthodontic training, but she, when she went back to work with them, she really did not want and love the idea of doing ortho, because it was the day that maybe she didn't really love in residency, because one day a week we had a pedo ortho come in and teach us all of this. Okay. And so she was already doing it, but then she learned about it, and she would be a great person to have to share her story. But her name's Lauren Ballinger. So she said to me to do that. And so I checked, and lo and behold, Alice was sleeping with her mouth open. Mm-hmm. And not just a little bit. I mean, it was like a good 4 to 5 millimeters, like you could see her, anteriors, her centrals. And so I was like, oh, Lauren, she's right. And so I sent her a picture and I said, okay, you're right. What do I need to do? And there wasn't anyone in Dallas at that time who was looking at all of this. And so I actually flew her to Massachusetts from Texas so Lauren could evaluate her. And she's like, bring her up. Let's take a CBCT. And around the same time, what's really interesting is that one of my colleagues, so my daughter Alice, who we're talking about, she had a really raspy voice. And I just thought it was really cute. Like I was like, oh, it's, you think, like I didn't think anything of it. And then another colleague of mine kind of put it in my mind, like, oh, well, what if she has polyps on her vocal cords? Like you need to go get her checked out by an ENT. And so we actually did that. It's so funny because all of this was happening around the same time. So I took her to see the ENT, and she did not want to get scoped because he told her, let's spray some medicine down your nose. And she was like, no, I don't want medicine down my nose. And I wanted to tell him, gosh, there's a better way to do that. Like if you would have told her you're spraying magic unicorn spray in her nose to make her...
Right, like the pediatric dentist in you was like, a little scripty, a little tell show do here. But
yeah, so she was not having it. So anywho, so he actually wanted to put her under. So this was before Lauren. I'm kind of backing up just a little bit. So he wanted to put her under to scope her. And then...
Oh, so this is before, and
This was just a few, maybe months before Lauren noticed all of this, okay?
But he never asked any other questions about...
No.
Oh, okay. Yep.
No.
Okay.
No other questions. Mm-hmm. So he said, let me just, her ears look fine. Her is the only way we'll know if we scope her, and let's just put her under. We can schedule her next week. And me being the person I was at the time, I was very robotic, follow the rules, and I still do follow the rules. I'm a rule follower, but I question things a little bit more now. And I was like, okay, sure, let's schedule her. So I went home to my husband, and he was like, really? We're going to put her under general anesthesia just to check? There are always risks and and let's just, I don't know. I don't feel comfortable with that. So I called and canceled right away because I wanted to be a good patient too. I didn't want to cancel the day of. So I canceled right away, and I said, I'm thinking about it and whatever. And they were fine with it. So then fast forward to Lauren, we take a CBCT, and she does her evaluation, and she had 3 tonsils. They weren't huge, but they were bigger. Her adenoid tissue wasn't that big, and she was a little narrow, deep bite, all the things that she could see just from a picture, which, now you and I probably see, just when you see any child walking around. Yep. And so we started with something super simple, nasal clearing every night, and she started wearing a little habit corrector from MyoBrace, it's called an infant trainer. And it was just so fascinating because before I even took Alice to Lauren, she had me take posture photos and just take some pictures at home, because it was like during COVID around this time. COVID was about to start, actually. So I kept sending her like update photos around this time. And oh gosh, no, maybe it was a year after. I think I took the posture photos of post during COVID. But anywho, it was just so fascinating to see her forward head posture before we started any, treatment, but when she was mouth breathing. And she was a pacifier baby, but I was a good pediatric dentist, and I stopped her passy habit at like 10 months, 11 months. And I thought that was really early, but she still had that open mouth posture. Like now it's interesting to see, like when she spit the passy out, the way she was at age 4, like right when she turned 4, is probably how she was at 11 months of age when she would spit it out. So just because we stop the passy doesn't mean that the mouth automatically knows what to do and the tongue knows what to do. I think she was just so used to sleeping that way. So clearing her nose, with a little xylitol, the X-Clear, and then wearing that little corrector really helped her. I mean, her deep bite, it didn't correct. I mean, but she was like 100% deep bite. She went to like 70%, and her posture changed. She just looked brighter. She didn't have the dark circles under her eyes. And this was before even any expansion, because I didn't really know. I mean, I did expansion when I first got it. I learned it in residency. I did it in the first practice I was in for about 5 years, because I was blessed to work with this amazing pediatric dentist who was in the mindset of, if something's off, let's fix it now. Like on 4 and 5-year-olds, we were fixing posterior cross bites when I was fresh out of residency, and we would take compound impressions. I don't know if you remember.
Oh, I do. We're similar age, so yeah.
Well. So compound impression, and we would fit the bands on there and send it off to the lab and make an expander and get these kids out of crossbite. And it wasn't for airway, and it wasn't for helping them breathe better. It was just getting them into normal occlusion because they were in malocclusion. So I had some experience doing that. And then, as I kept working, it was more hospital dentistry, OR cases, things like that, which I absolutely loved. But then once I learned with my daughter and I started seeing the changes, and I went back to the practice I was working in, because I was an associate, and I was very happy being an associate, not having to deal, with all the business ownership things. And I just couldn't see, my lenses completely changed. Like I wasn't just looking like before, I was just looking in a 2x2 little box of the mouth and the teeth, and are there cavities? Is there interproximal decay? Are you flossing? Just all of these things. Nutritional counseling, we would always talk about that. But I had never looked deeper. I never looked at how they were just sitting in my chair, all of them waiting for an exam, because they had little TVs across the way with their mouths open. Like I would say 90%.
Mouth open.
Yes, just waiting. Or we would see patients who had seen the orthodontist for a few phases of ortho, like, 12, 13, and then they'd go back in again at 16 because their open bite reopened. Why is that? Everyone was scratching their heads. Now looking back, it's like, oh my gosh, like, yes, tongue tie, or they need myofunctional therapy, maybe not tongue tie release. It could be just their posture, like the way that they're functioning. So I completely changed. I met Carla Damon, and we have this practice here in Dallas Beyond that focuses on craniofacial growth and development, but we also so we ended up getting so busy with this, like the growth and development part, tongue ties, airway, and that's the thing I explained, like we're not airway doctors, like we don't treat the airway, but we're helping things that could help the airway secondarily, right? Like we can't say like we're the ones, like we're going to fix everything. So we have 2 associates that work with us who also look at everything as well. And so they actually see all the comprehensive care patients in recares and operative. And Carla and I see all the growth and development, tongue tie, all of that. So it's kind of like we have 2 little mini practices, but it's all one practice.
Yeah. So
that's how I am where I am now.
Yes. That's why I love hearing people's stories. And thank you for sharing that, because so many people see you. You're a big name in this community now. You speak nationally. You're well known. They don't realize that you didn't start knowing any of this either. And I find that's really important to get that message out to people, because when I speak and lecture, I hear from people. They're like, I'll show cases when I didn't know what I was doing in this arena. I'll show cases that I mismanaged 15, 20 years ago. And they're like, I just kind of thought you always knew how to do this, or you always did that. I'm like, no, I completely didn't know how to do this. It was reevaluating my work, being self-reflective, being open to changing, and change is hard. It is hard. What you just described, I mean, obviously you gave a synopsis of it, but it leaves out the sort of gory details of how hard I'm sure it was for you to change your entire practice model. You're now building this practice with Carla, and like I said, you were happy being an associate. You had a role and you did it, and then you saw this, and I give you so much credit for not just keeping your head down and remaining myopic and keeping the blinders on and saying, well, I'm a pediatric dentist. This is what I do. This is what I'm trained to do. And yeah, maybe I could help there, but it's not really my role. You took the challenge. And so many people with whom I speak who are doing so well with this, it's because of their children. And I literally just got a text before we started recording from, you won't mind me saying his name, I'm sure, Scott Province, who's been on my show, and Scott's great. And I've been helping him and coaching him, and he's taken my approach on how I do this, and he's just doing amazing things. And he sent me a picture of his daughter and her friend with their big braces, smiles. I do this with phase 1 arch wires, and I do it with braces and wires instead of turnkey expanders in young kids. And I saw pictures before. They had dark circles under their eyes, and their faces like light up the picture. And it's so rewarding when you see what you can do to these kids. And I say this to my orthodontic colleagues all the time, is we can be so much more than just tooth straighteners. There's nothing wrong with straightening teeth. I love doing that as well. It just, we can be more than that. So speak to for a moment, because one of the things I find is really challenging is that change, not just in mindset, but in action. How did you do it? How did you go from thinking one way and not only having to transform your entire thought process, and you weren't like out just a couple of years, you'd been out many, many years, and then change how you practice, like literally change how you practice every day?
I just feel like it was meant to be. I mean, you know how things happen to you and it's like, oh, why are we going through this? And I feel like things come to you for a reason. And, you know, like I said, once I saw all the patients that were sitting there waiting for recare checkups with mouth, they were all mouth breathing, and we've never asked more questions. And then knowing that in 2017, the ADA released that position statement that we should be screening children for sleep disordered breathing and assessing more than just teeth, then, you know, like I said, I'm a rule follower. So I saw that, I'm like, oh my gosh, the ADA says that we must be doing this. Like that's something, I mean, it's highly recommended, but we should be doing this. And it's our duty, and we could change. I just saw how much I changed in my little one. And then, you know, my friend Lauren was sharing everything she's doing with her patients. And, you know, so I brought it up to the practice owner where I was working before. And, you know, it's hard, like you said, to change from a well-oiled machine doing pediatric dentistry. And so she was kind enough to allow us to start, because I was like, you know, we have to start implementing something. We have to start asking these questions, because I'm just that type. Like I just, if I know there's a right way, I'm going to do it the right way. Like, and I feel like ignoring it is wrong. Like you're doing your fellow, like as a human, you're doing your fellow parents as a mom too. Like I'm not helping them, and I'm in a position that I can really help put them in the right direction, in a better direction. And so we started adding the PSQ. So that's something that people could start doing right away, just adding that in. And you can add it to just one time, just add it into the recare, you know, if they've never had it before, or if they're a new patient, like in our office, whether you're coming for a chipped tooth as a limited exam or you're coming for a comp exam, you're filling out the PSQ.
Can you just, I think most people are aware of it, but maybe some don't. I have a bunch of laypersons that listen that may not be familiar with that. Can you explain the PSQ a little bit more?
Yes, yeah. So the Pediatric Sleep Questionnaire is a 22-question it's a validated tool that you can use to screen for pediatric sleep disordered breathing. And if there are more than eight yeses, like 33% or more, then you can suspect there's something going on during sleep. So some of the questions, like the first set of questions ask more about like snoring and mouth breathing. And then there's another set of questions that ask more about their habits. And then the last set of questions ask more about how their behavior is. Like, do the teachers say that they can't focus? You know, because a lot of times this was something that got to me in the very beginning when I was learning about this, is that ADHD a lot of times is maybe misdiagnosed, and that, you know, it's these patients aren't really sleeping well, and you can't really tell clinically which patients have, you know, sleep apnea or sleep disordered breathing or have true ADHD without a sleep study. And so this PSQ PSQ doesn't replace the sleep study, but so many people, it's hard to get a sleep study because of cost, because of timing. Sometimes
and sleep study accuracy, I mean, you ask the physicians and sleep physicians in kids, it depends on which lab you use, what rules they go by, whether they're using ASM guidelines in 2007 of 2 successive breaths or apnea or hypopnea, or going by the 10 or more seconds. And there's an article in 2012 by Yoon in Sleep Medicine Reviews, not Audrey Yoon, a different Yoon, about the first night effect. And literally in that article, they state that the first night that a child spends in a sleep lab, you can throw away the data, that it's completely irrelevant. Now, if there's someone who has moderate or severe disease, it tends to be detected. But for those mild cases, it's really hard to know. And I had a patient that they woke the patient up at 4 a.m. to stop the test. And this little guy was just turned 6 years old, suffocating. Mom showed me the video. He can't breathe. And I took a CBCT, obstruction of his adenoids, and it came back as he didn't have obstructive sleep apnea because he had no incidence of AHI. Well, we know that kids have a more active sympathetic nervous system. They have a more rapid respiratory rate. They don't typically desaturate for 10 or more seconds. It's much less common. And if they do, it tends to be later in the sleep cycles, in deep REM sleep, later in sleep. So if they stop the test at 4 a.m., there's a good chance they missed the 2 hours that this kid might have actually registered. So sleep studies in children, and I've learned this from sleep physicians, people like Jerry Simmons and pediatric ENTs I work with, you have to be very careful with them because ultimately pediatric sleep disordered breathing is a symptom-based diagnosis with a multifactorial etiology. It is not, you can take a test. And when I lecture on this, a lot of people don't realize that. And I think that's why we've gravitated towards OSA, because we can measure it, right? Like we're, in theory, we can measure it. There's a complete lack of normative data of pediatric sleep, period. It just hardly exists. There's really a paucity of data. And the pediatric scale, as many know, was developed from the adult scale. It was extrapolated from the adult scale, which was created in the 70s. There are no randomized controlled trials. I just had David McIntosh on the show recently, a brilliant ENT from Australia, and he was talking about this as well. I mean, no criticism to Dr. Guilleminault. I mean, he was a visionary and pioneer, but he was just trying to quantify some of what this sleep stuff was. Take it from that Pickwickian fat man syndrome to, this is like a problem in our society, and was just trying to create a scale. But they looked at asymptomatic men and women ages 40 to 60 years old is how they developed the original scale. And they literally, to quote Dr. McIntosh, they chose the scale parameters for adults because they were essentially numbers of convenience to put these sort of groups in. And then once it got latched onto by insurance and reimbursement and for CPAP, it's very hard to undo once you're that far down that hole. But for a sleep study for a child, I have had anybody who does this, when I speak with them, they have the same experience where they'll send a child who the parent shows them snoring, gasping. As Jerry Simmons says, no child should snore unless obviously they're acutely sick, but no child should be snoring routinely. And yet they go for a sleep study and it comes back fine, and they come back with 0. So again, it's so tricky. And I want to hear more about your thoughts on the diagnostics, on what you're doing in your practice, because that is harder, right? We like the ability to just take a test on something, right? Like blood glucose, what is it? Or blood pressure. We can measure these parameters and they're easy. Pediatric sleep disordered breathing it's a diagnosis based off of patient history and clinical symptoms. And that takes time. And that is something that, unfortunately, and I'd like to hear your thoughts on the pediatric dental side, on the orthodontic side, not enough of my orthodontic colleagues are taking enough time in their exams to really go through a PSQ, to ask these questions. It's more about looking at the teeth, seeing what's wrong, as you said, in that 2x2 box, and kind of making your decisions off of that. So what are you doing to incorporate some of those additional diagnostic capabilities, and how hard has that been, or not, to implement that into a pediatric practice? Hey everybody, I want to take a moment to tell you about this year's Airway Palooza, which is happening October 17th and 18th in beautiful Fort Lauderdale, Florida. This year's theme is From Downstream to Upstream, the life-saving shift, and will focus on something I'm a big proponent of, which is solving root causes to promote airway health as opposed to simply treating symptoms. That's why I'm honored to be co-chairing this event, and we have an amazing lineup of speakers, including general dentists, orthodontists, pediatric dentists, oral and maxillofacial surgeons, ENTs, board-certified sleep physicians, myofunctional therapists, lactation consultants, and craniofacial specialists, all in one conference setting. There will also be social events both evenings, so you'll have the opportunity to meet and brainstorm with colleagues beachside in Fort Lauderdale. Airway Palooza is the only airway-focused event to be nominated for Best Dental Conference of the Year. Plus, as a special gift for listeners of the Doc Podcast, you can receive a $500 discount off your registration fee by entering the code DOCPalooza at checkout. That's DOCPALOOZA to get $500 off your registration fee. I'll put a code along with a link to the conference registration page in the show notes for today's show. So don't miss out on this opportunity to participate in this amazing collaborative event. Get your tickets to Airway Palooza 2025 now before they sell out. And now, back to today's episode.
Yeah, so since starting this practice, we started, having the PSQ, like I said, in our intake. And so if they're coming for a cavity, they're not really there. They're like, why is a dentist asking about sleep, And,
Right.
And so we'll just go through it.
What do you say to them? Because I hear that a lot from people.
I just use the position statement 2017 that we are advised to look for this. And it's just something that we can see as dentists that, may be ignored or may not have been noticed before. And we just are here to ask questions, and we're here to help your child. Like, that's my take on everything, is I'm on your side. Like, I want to do anything I can to help your child get in a better place if they're not in a good place. If they're in a great place, great, keep doing what you're doing. But sometimes they think they're in a great place. So this is where the PSQ, having that in that intake, is, they check no to everything, and you see them there sitting in the chair.
I was going to ask you about that. Yeah, go.
And I don't say like, well, look at this. I see their mouth breathing. I can tell they have a deep bite, and I know that. So I'll just say, oh, I noticed, while little Johnny, while you and I are speaking, his lips are apart. Are they usually that way? And they'll say, yeah. Or sometimes they're like, oh, no, and it's like they know a little bit that they don't want to tell me that, but you can see clearly. So if they say yes, and I'll say, oh, well, what's really interesting, and I'll just talk about the importance of nose breathing and mouth breathing, and how when we're breathing through our nose, we usually get into better, deeper sleep. And that's where these questions come in. And so at first they may say no, or, because that's what I learned too, as I became so excited. As you see, I'm like, I love this like little niche in our field. Once I learned more, it was like diarrhea of the mouth. I would share too much. Not that you can ever, yes, you can share too much, but I wanted to share everything I knew. Cause like I said, I felt like it was my duty to share my knowledge. And some parents
just overwhelming.
They aren't ready to hear it. They aren't ready to accept it. They aren't ready, period. So I just, notice, oh, lips are apart, just watch for that. Like kind of what Lauren did with me. Check an hour or two after little Johnny goes to sleep for the next couple weeks and see if you notice that. We can talk about it more next time. And if their lips are together, then great. Just let me know that next time. And so next time they'll come in 6 months and they'll say, gosh, Dr. Loria, what you were talking about before, I actually noticed he moves all around the bed. His sheets are all over the place. He actually, does sleep with his mouth open. There's drooling, like his pillow's wet, and they'll start telling me more and more. And I don't even really have to ask. So I just plant seeds. Like I've learned not to overwhelm with, oh, your child has 10 cavities. Their behavior's horrible because they're not sleeping well, but their behavior's horrible. So they're going to probably need IV sedation and with an anesthesiologist. And then, we're going to talk about expansion, myofunctional therapy. Like it's too much. It's too much. Yeah. Even me as a parent, like if somebody came to me with like 20 things and nobody wants to hear there's something wrong with their child, right? Like there's
That's
nothing,
at the crux of all of that, right?
Exactly. So it's like, you came today for this. I saw this. Just see what you think and you tell me. And if they bring it up again, or we can just gently bring it up next time, like, oh, I remember last time, because, we have good notes, and or even with pacifiers, that's something else. Like, little Johnny has the Wubbanubs that have the animal on the end that I see those and I'm just like, and we just bring it up next time. Have we done, like we explained to them why it's important, what actually there was an article in the Pediatric Dental Journal about those specifically with the weight on them, how much force they exert on the palate and on the teeth. And it's enough to move teeth, and which it does because we see it. And I'll just like gently bring it up. Like, actually, there was an article about these, just something to look out for. If you're not ready to take away the pacifier, let's maybe switch to another type of pacifier, even though I'm like cringing when I say that. But, just baby steps. So I've just learned to go with the parents and try to guide them in a very gentle, nice way. I'll lead them toward, there's something I learned about at the AAPD conference this past January about this app called Pacified. Have you heard of this?
No, I haven't.
So it's really neat. It's this pediatric dentist. He measured like 1,000 pacifiers with a Boley gauge. And so he knows all the way. So what he's told us at the conference in a session that he had is that the pacifiers are very much towards marketing. And so at first, let's say a pacifier brand may have newborn, and then they have 0 to 3 size, 0 to 3 months, and 3 to 6 months, 6 to 9, 9 to 12. Well, if the 3 to 9 months aren't really selling, or the 3 to 12 months, then they just put them all together. And they give one size for 3 to 12 because they're not selling the 6 to 9 months, or they're not selling. So it's all marketing. And so you have to actually measure the width of the nipple. So he's made it really easy where you can take a picture of a baby, and with AI, it can tell kind of like what size palate, because one 6-month-old also may be a completely different size than another 6-month-old. And then the parents can put in what brand of pacifier they like to use. And so it can give like what size they should really be using. Like, even though they're 6 months, maybe they need to be using the 12-month pacifier. I just think that's really cool. And I had one of my hygienists here in the office, because she has a little one. Mine are too old to do this now. And so I asked her to try it, and she thought that they would have to take intraoral pictures, and she said it was simple. You just take a picture of the baby, and then they just pop out with like all these different sizes. So I feel like that's a resource, since it's made, and it's free, and it was made by a pediatric dentist who's like really super passionate about pacifiers.
Yeah, how cool.
Yeah,
wow.
Yeah,
I'm glad you explained that. I can even put a link in the show notes to it. So I love the approach. I love that you said baby steps, right? You said, well, first you explained the why. And I think that's something a lot of people skip. We know so much, and especially when we go on this journey, we get excited about it. We start to see all these things, and it can be really easy to overwhelm people who walk in the office. Barry Raphael and I were talking about this a little bit on his episode recently. He said he overdid it at first, right? He started learning about this, and they would come in, and he's like, oh, we got, your child isn't breathing and they're not sleeping, and that can cause brain damage. And, and people are like, get me out of here. This is just like, I don't like, what is going on? And so he had to learn to refine his approach as well. And I find that happens to most of us who do this because we become excited about it. And this is so outside of the reality of a lot of these patients and parents. The beautiful part with technology now is you can believe the majority of them, when you give them the why and you start to just probe a little bit, in those little teaser questions, they will go home and research it. And they will go and look of, is this a big deal? Does my child snoring at night or sleeping, mouth breathing have a problem? And then they're going to see and be like, ooh, this is something. And no one's going to want, as you said, something to be wrong with their child. So let them go on a bit of their own journey instead of them coming in and like forcing, like, we have to stop this right away. Like, you can't, no pun intended, but take a breath ourselves. Like, just calm down a little bit and let it develop a little bit. And then, yes, you're going to have some parents come in and they have already done Google and AI searches, and they're going to be quoting studies, but that's not the norm. And a lot of parents, it is going to be a challenge. And I face that in orthodontics. They come to me to see if their child is ready to start treatment at 6-7 years old, and I start talking about airway and adenoids and sinuses and seeing an allergist and maybe an ENT and helping them grow better. And so you have to be delicate in that and take those baby steps. So that's great. When you start to treat, what are some of your screening tools? So once you start to detect these issues, you're seeing there's a problem, and what are some of the things beyond the PSQ that when you get into a clinical exam now that you're doing clinically and radiographically to detect this? And at what ages are you doing those things?
Gosh, we start as early as 3, but if they're younger, there are other things we can do. But when, let's say, like ages 3 to 6 or 4 to 6, we see a lot of 4 to 6 year olds that come to us. We'll just do our clinical exam, look at occlusion, look at their air, like tonsils, Malamapati, tongue tie, lip tie. We look at TMJ too, just to feel if there's popping or clicking. I never really did that before, but I went to a conference that talked about how many kids actually start with this really young, just from like falls or like sliding down a swimming pool slide, and they bump the just different reasons. And so then after that, if I feel the PSQ that's significant, or if they mark on there, like even though I said, 8 yeses, but if they chart like the top 4, the top 3 that are more about snoring more than half the time, heavy, loud breathing, gasping, then we say, okay, a CBCT is indicated. And we can take that and we give parents, we just let them know, like, we see these things, we talked about it clinically. I see some things. Let's go ahead and take this 3D x-ray. And it's an ultra low dose. Like, we have the ICAP Flex in our office, and then we send it to a radiologist. We send it to beam readers for a report. And that way we get another set of eyes to look at everything. Because I can see all the basics, but I'm not a trained radiologist and I don't want to miss anything. So parents really like having that additional information. And that way too, if they go to see, if we recommend seeing an ENT, or if we recommend seeing anybody else, they have this report with them. Now, some ENTs like this report. Some ENTs I've heard said that the cost of the paper is worth more than the information on it, which broke my heart. But I asked I've asked like younger ENTs, and their response to that was, no, we like it. It's a tool. We're not going to diagnose anything from it, just like we're not. But, it's a great tool. And I said, well, what do you think about people who say they're not worth anything and it's not? And this one specific one told me that they just don't know how to read it. And they don't know, they just don't know, they just don't know. They're not, they're stuck in their ways that they learned, 50 years ago, and they're not going to change. So if you bring them something new, it's like, oh, why are you trying to give me something new? I already know how to diagnose without your extra information, little dentist,
Yes. Oh, without a doubt. No, I've heard multiple times. Yes. Yeah. Until you develop your group of, that's one of the things I teach on too, is how to develop that team, because you will get a lot of resistance from a lot of not only dental colleagues, but medical colleagues when you start this. So you've really got to develop your pack.
Yeah. So we do that. And then one of my team members, we actually used to do all the radiology report calls. Like, we would call the parents and go over everything with them. We just don't have time for that. So now we have a great team member, one of our hygienists actually, who's very passionate about this as well. I feel like all of my team, like, you just attract people who want to do this, and they see these things. And
without a doubt.
And yeah, so she'll call and talk to them about it. And then we just discuss next steps. So next steps in our office usually are, we refer to the ENT. We let the pediatrician know too, but sometimes parents have mentioned this, and this is where a lot of parents get frustrated, that they have seen these issues and they've been ignored or they've been downplayed. And so they come to us, and I see all these things, and, and they say, why didn't the pediatrician? I said, and I feel like I stick up for everybody. I'm like, well, they're busy treating really sick children. And, this is something that maybe they didn't have a lot of training in. Like, we've done extensive training. We've had a couple pediatricians that we've treated in our office. And I asked them, when I went through the radiology report with them, I said, please forgive me if you already know all these things I'm about to tell you, just tell me to keep going. And they were like, Loria, we had 1 hour of this in school. And these are pediatricians. Okay.
Yes.
So we don't know this. And
which gets into my problem with the AAO and the white paper that says defer to the pediatricians on all of this with children and let them quarterback the care. Like, that is the part of it that I call out. There are good parts of the white paper, but that was the part that I'm like, they literally want the orthodontist to take no responsibility. One major problem too is they make the whole thing is about OSA. It's not about sleep disordered breathing. And so we are discussed why that's an issue, but they literally say that it is not our place to diagnose it. Agreed. We're not diagnosing OSA, but they bypass sleep disordered breathing. And then they say, refer the patient, when they do say you should screen every patient for airway. They do say that in the white paper, but that you should then, when it's detected a problem, you refer them to the pediatrician and you let the pediatrician determine the treatment plan and refer them back. They say the physician, but in this case, obviously be a pediatrician, but even if it's a pediatric sleep physician, they refer them back to you and tell you what the treatment should be. And I'm like, why would we ask the pediatricians or even the sleep physicians to tell us how to do our job. Like, that's not their place. They don't want that responsibility, and they don't have the training in the treatment modalities. So yeah, I just sorry to interrupt on that, but that's one thing that I think is important for people to understand is the pediatricians don't, and self-admittedly will say, it's not a criticism, that they don't know about this. They're not being trained in this unless they go to special training, obviously. But
exactly. Yeah. Like what we've done, right? Like as a
exactly.
pediatric dentist, like once I learned about it, it's just I kept learning and you can't stop.
Yep.
So we refer to ENT, we refer to an allergist if we feel, they're always congested during allergy season or certain things, we just talk about that. We can refer to myofunctional therapist, sometimes OT, if you can just tell a child that needs OT, like they're just scared of everything, sensory, all these things. Then in our office, we can offer expansion. And we do upper lower expansion reverse pull face mask. We used to do a lot of because of my daughter, I was a big believer in myobrace at the beginning, and I think it's a great tool at certain times and as an interim support. But just from what I've seen, and even in our practice, you're not getting that true skeletal palatal expansion like we do with like our Haas expanders. So some kids that have a 10 millimeter deficiency that come in at age 6 and they're 21 millimeters, which we see that quite often, which is crazy to think. The myobrace, it could be a good desensitizer for starting treatment, so they can have something in their mouth for a few months, but then we know that we're going to start with expansion. So I think there's a time and place for that. Munchie is something that we also offer, and the Myo Munchie, which is that little device that they can chew on. And we start with that. Gosh, I mean, that's like a big one for the 1 to 3 year olds. I have pictures of patients with like these really crazy anterior crossbites where it's like F and G are in crossbite, and they use the munchie, and the parents that come to us, they notice something's off. Like you can see when the patient's biting that way, it's like a scissor bite in the anterior, and they start using the munchie, and that corrects after 6-8 months of using it every day, but in just for a few minutes. It's not like they have to sit there and chew for 10 minutes. But it's just really neat to see changes and be able to offer something. Even if I can't do treatment, it's just nice to be able to quarterback or be the person to say, hey, maybe you should go see a speech therapist that focuses on infant and toddler feeding, because they can only eat pouches and they're so selective. And, there maybe necessarily isn't a tongue tie, but they've always been low tone, or even body work. Like I'm a big believer now in body work. Whereas if you talked to me about a chiropractor 15 years ago, I would have kind of rolled my eyes and laughed. And now I completely think that a lot of kids need this. And I've seen changes with babies. We've just seen chiropractors and IBCLCs or feeding therapists, OTs that specialize in infant feeding and doing some body work, and then their feeding gets better. And we don't have to do a tongue tie release. There's some of them where it's like, yeah, I see a restriction, but I don't know that releasing this is going to fix everything. It's usually not one thing that fixes it. Something may be a bigger piece of the puzzle, but I think just working collaboratively with other providers, we can get really good changes and get better quality of life for these kids. And that's something that actually Dr. Barry Raphael shared that with our practice, is the quality. He has this little questionnaire that he gives parents after every, and he may have talked about this, after every visit, just to see like, how is sleep going? And it's just really neat, not just sleep. It's like, how are they doing in school? Are they grinding? Like just a bunch of questions that are a little similar to the Pediatric Sleep Questionnaire, but you can rate it from a 0 to a 10, 10 being the worst. It's so awesome to see kids that have been in expansion and they started off with like 10s, 9s, and 8s at the beginning. And then 8-9 months later, they're all 1s or not at all. Like just seeing, and that's how, like, how do you measure it? Like that's something a lot of people want data, and they want to know, how are you measuring these changes? Well, at the beginning, we did use the sleep image ring, or not ring, we used the sleep image, the little coupler that they wore on their chest, but then they switched to the ring, and we just had a hard time in our practice with the sleep image ring, so we stopped using it, because our plan at the beginning was, in this beginning meeting in 2020, was to take a sleep image before and after each patient, like after certain treatments, so we can see the data, like we can see the change in their sleep. Well, all the ring changed and all that during that time, so we just stopped doing it, and now we just do the quality of life questionnaire, and that's, all we can ask for, because the parents are happy. The kids, like you said, with the person that texts you the picture of the daughter and how their faces are so bright, like they look healthier. You can tell and when the child sleeps better, the whole family's happier.
Yep.
Right? So it makes everybody's quality of life better. So it's not just really the kids. When you see all ones, then you see the mom coming in and she actually put on a little makeup or, did something a little extra because she had time, because she wasn't fighting with a kid who was throwing tantrums all the time.
Right.
So that's just,
Or up at night hearing her child gasping for air, right? And worried. One of the videos I show sometimes when I lecture, his dad was a certified registered nurse anesthetist, and they would take turns, mom and dad, at night going in and propping the child's mandible up to help her oxygenate, because dad, in his profession, clearly understood the ramifications of not getting proper oxygenation. And they said, like, they would go in at night after I was treating her and expanding her, and she had already seen the ENT, interestingly, and great ENT. He's going to be on the show soon. He had was kind of like put her on Singulair, trying to see if something would work, but just her adenoids weren't really obstructive. She didn't have the narrowest airway. And once I developed those arches and got more tongue space and normalized her growth, it transformed her. And to hear the parents explain not only how it changed her life, the child, but their lives, and then like they're not going to bed at night worrying, is their child going to suffocate to death, literally. And they say that in their own words. They actually were guests on the podcast, my gosh, probably a year and a half ago now. And I treated their daughter, it has to be 2018, something like that, been a while back, and she's still doing wonderfully, and it solved all the issues. So, but yet when she came in, I knew none of that. She came in because she had a protrusive upper left central incisor, and she was 6, and the pediatric dentist sadly told her, don't bother going to the orthodontist. It's a waste of time. They're not going to do anything because she's too young. They're not going to do anything with her now. And when I went through what you talked about, the questionnaire, asking the questions, finding out more about her overall health, seeing the dark circles under her eyes, seeing the vertical growth pattern, seeing the high vaulted palate, the insufficient tongue space, asking mom the questions, it's like and I know you know this look, the parents' faces kind of look at you like, how do you know this? Like, how do you, and first of all, like, I came here for like you're saying before, for straightening teeth. And and she says that in the interview that I put out, made the video to, because she's like, why are you're asking me about the way she's sleeping? And you're right. So yeah, the power, but that, you also mentioned in that the process you go through, it takes time. It takes time. And that is, I think, one of the biggest obstacles to, at least in the orthodontic arena, my colleagues doing this, because they are used to being in that room for the diagnostics being a couple minutes and just trying to look real quick. We get so used to knowing when we look at a certain type of malocclusion, how we can treat it best in our hands. And I find that's one of the biggest obstacles I face in my orthodontic colleague community is the resistance to changing their entire way that they look at a patient. And that's hard. And I get it. I'm not even saying this as a criticism. It's just, it's hard. I went through it. You went through it. We both can personally attest to the fact, like, this isn't easy. That being said, the benefits when you start doing this, and I also love that you said about it's not one thing. And again, I think that's hard for a lot of us, right? Like, we see decay, we see caries, you know, you have a protocol based on the depth of it, what you do, how you treat it. We see certain types of malocclusions as orthodontists, certain millimeters of crowding, and we say, I'm going to treat it this way. This doesn't fall in a neat little box. And there's such phenotypic variation in how these patients present to us. We have to be sort of these detectives to get it right. I mean, we have to
absolutely, yes,
investigate this stuff. And then, as you said, you see certain positive indicators on a PSQ. So then you say it warrants a cone beam, and then you're looking at that, and then you're trying to figure out, do you work with the ENT, with the allergist, with both? Do you need to go in and do arch development expansion? Is there a tongue tie? We'll come to this more in a minute. And is that going to help them? Is there myo involved? Is there OT involved? And I get feedback from a lot of people when I'm coaching and teaching, and that's so overwhelming to them to even think about that. So when you started this, on this journey, after you went through what you went through with your daughter, and Lauren had kind of alerted you to some of this, and you went to that seen your doc and asked about implementing it in the practice. One of the questions I get from a lot of people is like, how do you start? Like, where do you start? Because you've come so far in such a short period of time. So it's awesome because it shows people it's possible to do this. I think we'd both agree it's not easy to just like, you're not gonna like turn a switch and all of a sudden in a day have this part of your practice, right? So how do you advise our colleagues who believe in what you're saying? They understand that we can do more and be more for our patients. They just don't know where to begin. And on that, they may have tried. Like they may have tried to send to ENTs and the patient comes back and they won't see that they won't do anything with the patient or an allergist. And they're frustrated and they feel that they can't do it. Have you heard about the doc community on Facebook? It's where you can get access to more great content, including case reviews, select clips from CE courses and podcasts, literature reviews, and exclusive promotions and discounts off doc educational materials. Just go to Facebook and search for the doc community and submit a request to join the group. And now back to the podcast.
So with incorporating the PSQ, there's a letter that I can share with you and you can share with everybody that Lauren actually shared with me, just explaining why we're asking these questions. So that way people who've been coming for 18 years to the office are all of a sudden, or, not 18, usually they're out by then, but let's say 15 years. Mm-hmm. And it's like now they're 17, 18. Why are you asking me these questions now? I've been coming here forever. Right. And so the letter just states about the 2017 policy statement from the ADA and that we as dentists can look at all of this. And now we've incorporated it into our practice so we can screen for things, and we're just here to help, like if there's something going on. And so most parents in that practice would answer the PSQ and that was it, and then we could talk to them about it. And at the bottom, we would check off, because at that time she didn't have a CBCT, and we would actually there was an orthodontist that was nearby actually that would take a CBCT for our office if we felt it was indicated. Okay. And he would actually do it, I think at no charge, just because, and they would just pay the beam readers report. And so he was, more airway open-minded, it wasn't like, let's start seeing all these patients, but this, he wanted to make the pediatric dentist happy. So he was taking the CBCTs and then we would get the report back and we would just go over it with parents and just share with them next steps. So the thing with finding, let's say they go to an ENT and we know, like, let's say specifically like around in this area, like in North Texas, there's a group of like a few ENTs and we know who to send to out of that group if they're going to go there, because two of them are very closed-minded and then the other one is very open-minded and is actually taking into account the quality of life, how they're sleeping. It's not just all about a sleep study, and which, yes, I know that's the gold standard and that can help them, have numbers and see how things get better. But, I think it's just find your people. So just because if you send something to one person or even a speech therapist and you think there's maybe tongue tie and you want them to work on tongue strength, and you may not have a myofunctional therapist in your area, there are actually people who do video, like virtual. Yeah, sorry. Yep. And so they can. There are other. You can always find somebody. You can find your pack, and then once they start hearing about, oh gosh, now they're sending here because I'm not looking at this, then they may open their eyes. And that's the thing I say too for pediatric dentists, like looking at this, like we should be looking at this, because you don't know how many people we see in our practice that are like, gosh, we've been going to see this pediatric dentist for 5 years, and I just share the same thing I do about pediatricians. I learned about this because of my daughter. It's not something that's really taught in residency. But then guess what? They want to move everybody over, their whole family, to another practice. So people will lose patience, I think, if they're not looking at this overall, looking at everything. And I don't want that. Like, I don't want to take, and I'm not, I would say, no, you should stay with them. We can send them correspondence and then they choose what they want to do. I can't force anybody. But yeah, I think that ENTs, even other doctors, like, or SLPs, if they're not looking at this, they may lose seeing patients, and maybe patients they can potentially really help. Yeah. So I think just as the word spreads, I think moms drive a lot of things. Yes. And when moms are persistent, they will get something done. So if they don't find the person that's right, they're going to go to the next person, or they talk in there, which we all know Facebook groups can be a blessing and a curse. Yep. And, because of crazy things that they hear on these, but then sometimes they're like, hey, who can I go to for this? And that's how we have patients coming from like surrounding states to us to come see us for this, which is crazy because it's something that maybe they could see somebody nearby and see, like even here in Dallas now, I have great connections with orthodontists who will treat at age 7, 8, and 9 because I just don't have time to see all these kids that need this. So they come to us, and we got to a point where we were only like seeing the 4 to 6-year-olds, but then we got a lot of angry moms saying, I heard that y'all do this and we really need your help. And so now we're still seeing like the 7, 8, 9-year-olds, but just they know that we're not going to treat them because I'm doing more orthopedics. Like I'm doing the expansion. I do not do brackets. We kind of, did 1 or 2 cases with brackets and just decided, you know what, I'm going to let the orthodontist do that. Like that's, in my opinion, when we're doing this work, it's actually making the work for the orthodontist later on not easier, but not as challenging, right?
Oh, certainly. Yeah.
Because like my son, he has beautifully developed arches. He's 12 now, but I'm still taking him because my idea of perfection is I want it perfect. So he's going to get orthodontics for maybe 12 months versus, what is the norm? Like 24 months is average, would you say, on somebody that didn't have anything? So that's what I tell parents is I'm not guaranteeing we're not going to need braces. And, but this is just going to get their bone in a better place so the teeth can erupt into good. Like Mariana Evans says, I feel like she's one of my biggest mentors who's taught me so much about this because she's, both ortho and a periodontist. Just they erupt into good juicy bone. Yes. And that way we can potentially decrease the chances of later on needing any type of bone grafts, gum grafts, recession, so many things that adults get or that even orthodontists proactively do. So that way they can move the teeth into bone that's not supported. And so when we have parents that, a lot of these parents that come see us have been through this themselves as adults or later just like late teenagers, and then they're needing corrections, and so they want to try to avoid or do whatever they can to decrease the complexity of their child's case because they know how complex they were. So
that's very well said. You said a lot there, really great pearls, and thank you for explaining that trajectory because it is a process and it's not going to be perfect and you're not going to have the right answer for everybody or every case. And I love too, you talked about you're not telling people this is going to prevent the need for braces. That is, I hear that from some people. It's like, that's where you start to get people thinking that this whole movement to be more proactive with care and help redirect growth and development and establish nasal breathing, they start to question it because they're like, well, the orthodontist then gets these patients later on and the parents are like, well, they told us if we did all this, they wouldn't need braces. And now you're saying we do. And I always say to residents, never lie to your patients or the parents. Always be truthful. And as you said, you're going to develop the foundations. You're going to help them. You're going to, as Jeff Rouse says, normalize the anatomy, right? You're going to try to get them growing correctly. And getting them nasal breathing is a big part of that. And then the teeth still may not come in perfectly straight, but at least they're coming in on solid foundations. And you're now not trying to fit teeth to faulty foundations that don't line up properly. Interestingly, a lot of the orthodontists will say, well, you can't expand canine width, which again, there's studies by Little and Rydell done in the 80s into the 90s, and it's a bunch of studies that talk about, actually some even before that talk about, expansion of inner canine width. Well, the studies are all based on doing it with the permanent teeth after they have erupted too narrow. So yet if you develop that bone and that alveolar bone young, use the baby teeth and the primary teeth to develop and expand the alveolar bone, the permanent teeth erupt into sound bone and wider, and you're not dealing with that problem later on down the road. And it's like, again, it just trying to change that mindset. So what has been you mentioned the relationship with some of the orthodontists. What has been the feedback you've received from the orthodontic community when they hear you are treating patients to help redirect their growth and development between the ages of 3 and 6 years old?
I mean, they're not like, hooray, yay, Loria's doing this. But because I've been around for a little bit, it's not like I'm a new grad, like coming out just doing this. I've had some orthodontists say, well, if she thinks that that's what's needed, then I see that. It's just I don't treat that age. Like they'll admit that.
Great for them.
Then we have one that said, because we, at the beginning, so I've learned just, you learn through ways of wording things, how you can make things better. Because we would talk about, we would expand the upper and the lower, like the lower arch. Well, They went to an orthodontist. You can't expand the jaw. There are no sutures there. Like, what is this pediatric? So now we're like, we're going to upright the molars, decrowd the anterior teeth.
Don't feel bad about that. They say the same thing when I say it too, even though I'm an orthodontist.
So I've learned, and even when I talk about it with parents, like I never say expand the lower, even though we're expanding the arches. We're like actually changing the growth of the arches, but I'll just say we're uprighting the lower teeth and decrowding the anterior teeth. And we're doing this so that way we can get maximum expansion with this expander, because I can only expand so much without having them have a telescoping bite. And I'll show them like with my hands, I'll do this to show them. And they're like, oh, that makes sense. And I'm like, and plus you want to have good, what's called in our world, axial loading. You want the teeth having a good bite in the back. So that way the jaw joints are protected. And once you explain it to them, and it doesn't take me like now I can go in and explain things I feel like in 10 minutes where I used to take like 40 minutes.
Yes. And that's important too. It is important to slim it down. Because,
And they're like, that makes sense. And then, we talk about, because I have a lot of patients that come in to me for tongue tie evaluations. Since I'm an affiliate of the Breathe Institute, there's like a handful.
Talk a little more about that if you would. How you approach releases, when you do it, how you know if you're using Sarouche's criteria, the different, the tip and the
LPS.
LPS. So whether using the tip and the LPS, and are you using those? Are you
not
using
only
those scoring?
So I'm an affiliate, like I said, of Dr. Zaghi. So I've had one-on-one training with him. So there are only like 5 or 6 pediatric dentists in the country who've had this training. The reason why I wanted to learn, I remember when he asked me, I heard him speak a few times, and finally I had the courage to go up to him and say, Dr. Zaghi, I want to learn from you one-on-one. He's like, what do you want to learn, Loria? Like, why? Why would you want to learn from me? And I said, I want to know exactly how deep to go, because I'd started doing tongue tie releases, but it's just, under there, it gets like, oh gosh, how far do I go? Is this too far? Is this not enough? Is the therapist going to say I didn't do enough? And then also I wanted to learn how to be an amazing suturer. That's the word. Like somebody, like I wanted to learn to suture really well, really quickly, know exactly how far apart. And so, he's like, yeah, we can do that. So I had to like fill out an application. It was like going through like a little mini residency. I had to like fill out my application, And so I went and flew out and watched him for a few days. He came to our office with his team, and we had, I think we had like 40 different procedures that we did. Like it was like back to back to back. And he was there literally holding my hand, like showing me where to go, what to do, how far to go. So I absolutely follow his protocol in anything new that he does. Because he's done so much for research, and, as an ENT sleep surgeon, like he's just phenomenal, and he blows my mind every time I hear him speak. Tongue tie releases, I will not. So when they come to my office, then I always explain to the parents before I look in the mouth, and granted, like sometimes, or not sometimes, all the time, my assistant or my hygienist who does the intake will measure intermolar width, like bogue between if they have primary molars, intercanine, like we measure everything in the mouth. And if they have no space, then I know I'm not doing a release yet. So if they're really narrow, like these little 21 millimeter pallets that come in, if I go in and release a tongue tie, where will that tongue live? And that's what I explain to the parents. So when I first sit down, I'll start telling them, I'm going to look at your child. I'm going to be looking at their teeth and their palate and everything. I know y'all are here for tongue tie. I'm not going to jump directly to that. I'm going to look at other things too. And then we'll talk about what I see. And they're like, okay. So I go and look, and then I have them. So the biggest thing that parents see and they can understand it and get it is, I'll do all my little measurements too, and then I'll have them do a suction holder if they can't, because a lot of these kids can't. We get them to start clicking their tongue. Click, click, click. Okay, do it harder, do it faster. And that way you can see the tongue, and you can see the overflow over the lateral borders of the tongue. And if it's completely overflowing onto the occlusal surface, on the chewing surface, then I'll let them know, this isn't going to have space to heal. Like I can do it. There's no space for it to heal. And then I can also go into, it just depends on, I always read the parent. Then I don't want snoring to get worse, or I don't want these sleep symptoms, because if the tongue can't go, if there's no room for the tongue to fit in the mouth, it's not going to go back, because it's going to completely obstruct the airway. So it's going to go forward. And we may have, since we have low tongue posture, you may have even more open mouth posture. So, once you explain that we need the tongue space first, then great. If they have enough tongue space, then I I always refer for myofunctional therapy. We have a wonderful hygienist in our office who's trained through the Breathe Institute to do myofunctional therapy. But I would say maybe like 20-30% of our patients see her. I send most of them out to other therapists that either live closer, because like I said, we have people who come from a ways because it's a little more frequent visit. So they'll see somebody closer to them, or if they need somebody who has a speech background, I want to send them to someone who's an SLP trained in myofunctional therapy. So it just depends. And I can also sometimes read patients, like if they need someone in person versus if they can have someone virtual.
Yep.
So I actually have a form that I made that I filled out, or that I have the therapist fill out, because I also learned from previous things. I released a tongue on a patient who could suction hold for 2 minutes, had my criteria, but the therapist wasn't really ready for them to have the release yet. But the mom called our office and she said, "Hey, little Johnny's ready for his release." The SLP gave the okay. And, you take that as okay, great. Yeah, we scheduled him. I did it. Then I send my post-op letter and I get an angry phone call. "Why did you release this tongue? This patient wasn't ready yet." And I'm like, "Oh my gosh, I didn't know that. The mom said that they're ready and they could do suction hold." And so I've learned just collaboratively, we have to all decide we're ready for this. So I have the therapist actually fill out a form saying functionally this patient is ready for a release. So great, I will not do it unless I have that in my chart. And then they know that they have to follow up with the therapist afterwards as well. So they come in, I do the release after the therapist says, they're good to go. And I usually do it with laughing gas and just like Dr. Zaghi does. I think the extra thing I do is the laughing gas, because as a pediatric dentist, I find it great for patients. And then they usually will see the therapist 3 to 5 days afterwards. And then we usually do a 2-week post-op call. And then I have them in our office 2 months, because that's when I can really see how healing is. Okay. And then depending on what that looks like, then we, say, okay, you're good to go. And I have one amazing orthodontist in the area who, especially when he's about to do a herpes or do something to help develop the jaw, if they're tongue-tied, if there's enough space, because he knows, ideally, and everybody knows I like to have the most space possible, but if they're about 33 millimeters and I see that there's enough space for the tongue, we maybe have mild overflow, I'll go ahead and do it, because that way he can optimize. He said he sees changes when they have had their tongue tie released to allow that jaw to come forward, because when you pull back, his thing is when the force of the tongue tie is pulling one way and you're trying to, help the jaw go another way, it's counteractive forces. So yeah, I get referrals from all different types and then refer to whoever I need to so we can have good outcomes. And that's what I'll tell parents. They'll say, "Oh, so we can't do it today." We have, some random people who Google search us and they want to do a tongue tie, they know their child has it and they want to do it right away. No, I'm sorry, this isn't the practice. If that's what you want, I'm sure you could find somebody who does, but this is why I don't do it that way. And when you explain that, they're usually like, "Oh, well, yeah, I want to do it this way." So it's the functional frenuloplasty that I truly believe in. And I see if we don't have good outcomes, it's usually because when there's not enough space or if they've had poor myofunctional therapy. So I've become very strict on the myo. And I've had, if I'm newly working with patient or with a provider, I'll have them come in a week or two before the release to make sure that they're good that way, because I don't want them to show up the day of and be like, "Actually, your child can't suction hold and you can't do these things and we're not doing it today." Yep. And they've coordinated all this body work and all these things around this procedure appointment. So I have them come in a few weeks beforehand. So when they call to schedule, yes, the provider said we're ready to go, they'll schedule a readiness check is what we call it. And then 2 weeks later, they schedule the frenuloplasty. So that way they're back to back, and it's really good for patients because that way they know what to expect. Providers that I work with a lot, they just do the readiness check in their office because they've come to observe me and they know how to explain everything to parents. So that's how I do tongue ties.
So
for
awesome.
Children. Thanks.
I love your thoroughness. I love your attention to detail. I love how you think about these things. You're not just doing procedures. And, I really wish my orthodontic colleagues who question the manner in which you're practicing or that people are being more proactive in doing some of these things, I just wish they would listen to this episode. And so if there's someone out there that you think is skeptical of this, please share this, because it's obvious that you have put so much time and energy into this. You're not just doing this to have a billable procedure, right? If you were just whipping people in, doing releases, getting them out, not caring about the follow-up. I mean, you are doing so much from your diagnostics to your patient education, parent education, coordination of care with your colleagues. It's really admirable and it's really great. And it shows, I think, sadly, and I keep saying this, and I've said it many times to you, and I say it many times on this show and when I lecture, I think that's part of the reason not a lot of people are doing this, because it is that much work. You think you've done both, right? You've done both. I would be willing to bet, and tell me if I'm wrong, but I would be willing to bet you have way more responsibilities and way more boxes to check and checklists and things to look after now than when you were just doing routine pediatric dentistry, right?
Oh, absolutely. 100%. Yes.
Yeah. And you strike me as a checklist person and a box person, and that's not a bad thing. Having that checklist, having that, and that actually ties into kind of how I want to finish up talking about this. I've kind of been stricken by the fact from early on when I was talking with Stacy Becker about this, and as I was on this journey and I started the podcast, I started noticing that female docs get this a lot more easily than male docs. And I don't have any hard data to prove that. It's just a sense I get from talking to a lot of people about this. I feel like there may be something, the maternal instinct, maybe it's but I feel like in the men we're that sort of hunt and kill, right? Like we want to treat that case and get them to class 1, and this is what we were taught to do, and I'm going to be the best tooth straightener I can be. And I don't say that in a mocking way. I was that person like for a while, so I get it. I feel like it's a harder process to convince my male colleagues to think the way that you think than it is a lot of female colleagues. Not across the board. It's not 100%. I'm not painting everyone with that broad brush. Have you seen that? Do you feel like the female docs tend to embrace this concept a little more easily than the male docs?
I do. I feel just like you said, I think a lot of us are moms who've gone through this, and we just have that instinct, and just treating other or helping other moms. I think sometimes moms like hearing from other females, but then when they do hear, I think, from other males, it's like, because the orthodontists that I work with, some are male and they get it and they're like, oh my gosh, like it's actually somebody that listens, and they're looking at the full picture, and it's not just about straight teeth. Yeah. And my thing for like people who want to see like immediate before and afters, or want to have like, I want to straighten the teeth and be finished with the case. Well, if you look at all of these extra things and look at if we could do a little myofunctional therapy, or if they have allergies, then as an orthodontist, you will have better outcomes and stable cases, right?
Yes.
And patients that aren't coming back 2 years later, like, why is this moving? Or why is this like this? Well, maybe if we looked at some things a little bit deeper and dove a little bit deeper, asked some more questions. And yes, that takes a little bit longer, but then think about the headache it can save later on, because we don't like having, like, we like doing things and doing it well, and that's it. Like, I don't want to hear any problems. If there are, of course, we do whatever we can, and we stay up late at night, right? If there's something wrong, like thinking, how could I do it better? Well, this is maybe something that is missing from the orthodontic profession, or any profession, like whoever's, doing braces and Invisalign, things like that, you may not have stable cases for a long time. So I think when you put in the work a little bit more at the beginning, then you'll be happier and patients will be happier later on.
Yeah, it's so true. It's that time. It's kind of like anything. It's that delayed gratification. When you do the work early, the results almost always are better when you take the time. And we're in such an instant gratification world, and I want it done right away and straighten the teeth as quickly as we can. And then there's a failure, so we try to straighten the teeth again, which didn't work the first time. And so we get caught up in that because that's the toolbox we have, right? But if we can just change our mindset and think about it differently, it opens up such just a whole host of possibilities. And at a recent episode that'll be coming out just prior to yours with Beth Lambert, and talking about chronic disease in children. This gets big. Like, this gets really big. And I do think that's maybe why a lot of the females tend to be a little more in tune to it. And in fairness too, when I was going through this process and journey with the parents in the practice, it was typically the moms who were on board before the dads. The dads are kind of looking like, what's this going to run me? Like, how much am I in for? You're talking about a lot of things here, doc. Like, this is going to, and it's not a criticism. I think it's just, again, kind of a male female thing. We're just wired differently that way. And the moms are more like, yes, something is wrong with my child. They do wake up this way. And dad's like, I don't know. I think they wake up fine. It's just kind of how we are. And I think that's why the moms need to be huge advocates for this, and moms out there listening, because I know there are a lot that listen to this show. Fight for your child's health care. Fight
Absolutely.
for their health. I can't tell you how many moms they say they came to my office the first time at 8-9 years old, right? And I would detect these issues. And I mean, I had moms in tears because they felt like failures as moms. They're like, Dr. Mike, I knew it. I knew something was wrong and no one would listen to me. So if you're a mom out there that knows it, fight for it. Your child shouldn't be snoring. They shouldn't be mouth breathing. They shouldn't be posture with their neck forward and head forward and a big curve in their C-spine. They shouldn't be grouchy when they wake up in the morning and exhausted. They're not that the only cause of ADHD is sleep, but it certainly is a contributing factor. So before they put the child on speed, Ritalin or Adderall, let's please try to just do probing questions. Could it be the way they're breathing? When that ENT tells you they're not going to, because you made a great point with your little one. Like a lot of people don't realize they don't do endoscopy. Everyone's like, well, CBCT, endoscopy is the gold standard for looking at adenoids and pharyngeal airway. Point conceded, but they're not doing it. So CBCT is certainly a lot better, because when you take those images and then screenshot them or send the CD to the ENT, which is one of the things I teach to do, take images, pictures, send them along to the ENT. It's really hard for them to ignore when they see that type of obstruction in a three-dimensional image like that. Same thing with the allergist, right? Get them. If your moms are out there, they're always stuffy. I gotta, kind of that little like snot-nosed kid, like they're always just a goopy. Well, that's not normal. Right. And that can be a sign of major chronic allergies starting. And if we can get them to the allergist and manage some of these symptoms, then not only is it a healthier child, but they're going to breathe better, et cetera, et cetera. So again, I'm glad you hit on that. And speaking on the topic of moms, so how do you do all you do? Because how many little ones do you have?
I have 2. They're 10 and 12 now. Yeah.
10 and 12. Busy ages. As a dad of now a 19-year-old and 16-year-old.
Oh, wow.
I get it. 10 and 12 is a busy age. So you're a mom, you're a wife, you're a business owner, you're an amazing provider in the pediatric dental arena. And you're a colleague. It's not like you just have your own practice. You have to be sensitive to others that you're practicing with.
Yeah.
How do you do it all?
Gosh, it's just having these parents that come give me these changes like fuels me. Mm-hmm. And so I practice what I preach. I sleep well every night. Good. I wake up at 5 a.m. I go out, work out, lift weights in the gym 3 times a week. Mm-hmm. I eat well. I have an amazing husband. Like that's something too. You said I'm a dentist and a mom, and I'm married and have a person that supports me fully because he has some of these issues that maybe could have been prevented if it were treated when he was younger. Like he had ortho, but when I remember when we were first dating, I took impressions to make him bleaching trays. I thought that'd be like a really cool thing to do. And I'll never forget when I articulated his teeth together. I was like, oh my gosh, he's so classed. Like he has like a 4mm overjet. I'd already fallen in love with him by that point. So he's gone through all this. He has some things, and he just really sees the changes that can be made early, and he truly supports what I do. So I think it's just having like that family support. Like my kids every day are like, Mommy, did somebody say, like we talk at dinner, and I have dinner with my family every night. Like I just, you have to have, I have a schedule, it's just like we do this, like these are very important things to me. And then running this practice too. And my team, I just love them so much because and I tell them it's not me doing all of this work. Like, yeah, I help, quarterback all this stuff, but it comes from the first phone call to the experience they have in our practice. And they all know I have very high expectations. Like I always say, like we're a premier pediatric dental practice. I want to keep that. Like if something's done, I'm like, is that premier? No. So let's change that.
Nope. Definitely not.
Yeah. Yep. So it's just having, I guess, expectations and just structure, and just know that if you want to do something, you can do it, and nothing is impossible. I mean, I wish I had this like with my son who's 12, and that's like a whole nother podcast, but I had issues with nursing. So just now with babies, I wish I knew the things I know now with my son. I was in the corner of my kitchen crying because I couldn't breastfeed him, and nobody mentioned anything. And he was born in sympathetic C-section, and nobody said anything about he's just very alert. Like that was the thing that I got when he was a baby. So just knowing that now I can share these things I've learned, like I said, I feel like things happen and come to you for a reason. And if you're listening to this today, it's for a reason. As a provider, you can go change lives. As a parent, you can do something more for your child and just go, like Dr. Mike, you just said, fight for your child. Be proactive. Don't just wait till things get bad into where you have to do all these things. You can maybe start when things are, let's say, stage 1. We have just a little mouth breathing and just correct that. And the earlier you start, usually the interventions aren't as intense. And, the later you go, like even as an adult, you can still get all of this corrected and get help, but it's a lot more challenging, a lot more involved. It takes a lot more time, finance, like everything. So I just think that we're in a position to really do a lot of good in this world. And that's my thing, is just changing to make life a bit, like it's so cliche, but just making the world a better place, period.
You are. I'm not just saying that. You are. You're a rock star, and so impressive in your approach to this, your level-headedness. You're very pragmatic, but just so driven and really goal-oriented and answering to something greater. And it's just such an inspiration. So I'm thankful for you sharing all of that and being open and honest on how you do this and how you're helping. You're changing lives. This is what this is about. That's why I do this podcast, is I want to get out there that we can change lives. There's nothing wrong with helping treat dental decay or straighten teeth in the orthodontic arena. I'm not mocking that or saying that's insufficient. There can be so much more that we can do, and we just need to embrace that. And you're such an inspiration, not only on a professional level but on a personal level. As a mom, to be a mom, there's a lot of moms. I get a lot of people that reach out to me, and it's hard to manage it all. So the fact that you're doing that, staying structured and keeping your health intact, that's great. So it's
Thank
awesome.
you.
This was an absolutely awesome conversation. I really appreciate you coming on the show. And how can people reach you if they want to reach out or learn more about what you're doing or your practice?
Yeah. So Instagram, Beyond Pediatric Dentistry, and then I even have like a professional Instagram. It's Dr. Loria, DOCTOR, Loria, LORIA. Okay. So, yeah.
Awesome. I'll put those in the show notes. Dr. Loria Nahatis, what an absolute pleasure. Keep doing it. Keep kicking butt out there. You're a rock star. Keep it up.
Thank you.
All right. Great talking with you.
You too. Thank you.
Bye.
Bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.